Imagine you're walking into just a brightly lit room. There is a patient lying in the bed, looking pale, breathing just a little too fast, you know.
Yeah, classic scene.
Right. And the monitors are softly chiming in the background, flashing dozens of different colors. And you pull up their electronic health record, and you were immediately hit with just this wall of data.
A complete avalanche of numbers.
Exactly. We are talking hundreds of data points. Heart rate, blood pressure, respiratory rate, temperature, oxygen saturation. And then there are the laboratory results.
Oh, the laboratory results. Page after page of them.
Right. Page after page of metabolic panels, complete blood counts, coagulation times. Plus, you have the patient's extensive medical history, the medications they took this morning, the medications they were supposed to take in like 5 minutes, and notes from 3 different specialists.
It's a lot. To an untrained eye, it is just a chaotic blizzard of information.
A total blizzard. But as a professional, you're expected to look at that blizzard, pick out one single snowflake, and realize that that specific snowflake is about to trigger an avalanche.
And that is an incredibly heavy cognitive burden. The sheer volume of information a healthcare professional has to process in a matter of seconds is staggering.
I can't even imagine.
I mean, you are not just reading data, you are essentially trying to predict the future based on a constantly shifting set of variables.
And if you get it wrong, the consequences are not just, well, a bad day at the office. We are talking about human lives.
Exactly. Lives are literally on the line.
So welcome back to the Nursing Launchpad program, right here on the Licensed Practical Nurse Launchpad channel. I am so thrilled to have you with us again as we continue our deep dive into the material, really looking into the mechanics of patient care.
It's great to be back. We have a lot to cover today.
We really do. So just to recap for you listening at home, in part 1 of this series, we laid down the foundational steps of the traditional nursing process. We talked about assessment, diagnosis, planning, implementation, and evaluation.
Right, the absolute bedrock.
Exactly, the bedrock. It is the broad, overarching framework that gives a sense of order to what would otherwise be absolute chaos.
Because that traditional process gives you the categories of care,
Right.
It is an excellent organizing principle for stepping back and really looking at the big picture of a patient's journey through the healthcare system.
But today we are zooming all the way in. We are
Yeah.
picking up exactly where we left off, and we are focusing entirely on something called the Clinical Judgment Measurement Model.
Yes, developed by the National Council of State Boards of Nursing.
Right, the National Council of State Boards of Nursing. And this model is where we move from the theory of care into the absolute trenches of real-time decision-making.
Into the action.
Exactly, the action. Because having vast medical knowledge, knowing the intricate details of human anatomy, memorizing the side effects of every single drug in the pharmacy, that is fundamentally useless if you cannot translate it into safe, effective action when a patient starts crashing right in front of you.
And that specific gap between knowing and doing, is precisely why this model was developed in the first place.
Really? So it was born out of a specific need.
Oh, absolutely. The National Council of State Boards of Nursing recognized a critical issue in healthcare. They analyzed massive amounts of data regarding patient care errors, and what they found was actually fascinating.
What did they find?
Well, the errors were rarely happening because a nurse simply lacked factual knowledge.
Wait, really? So they knew the facts?
Yeah. The nurse usually knew what the medication was. They knew what the disease process was. The failure was happening in the application of that knowledge under pressure.
Wow, okay.
Right. It was the transition from a static textbook understanding of the human body to a dynamic, fluid interpretation of a living, breathing patient who is deteriorating in real time.
So it's kind of like the difference between knowing how a combustion engine works on paper
Yeah.
and actually being able to drive a car on an icy highway at night while avoiding a collision.
That is a perfect analogy. You can memorize the driver's manual all you want, but the manual cannot tell you how hard to hit the brakes when a deer jumps into the road.
Right, exactly.
The clinical judgment measurement model is the cognitive engine that actually allows you to drive. It is a highly specific 6-step mental framework that operates minute by minute, second by second, inside a nurse's mind to navigate complex and rapidly changing situations.
That is so cool. I really want to break down those 6 cognitive skills today, but I do not want to just read a list of definitions.
No, nobody wants that.
Right. That never helps anyone actually understand how something works in the real world.
Yeah.
So we are going to follow a specific patient scenario from the moment the nurse walks into the room all the way to the end of the intervention.
I love that idea. Setting a concrete scene is definitely the best way to unpack this.
We are going to put this cognitive engine on a test track and see exactly how it runs.
Let's do it. Where are we starting?
All right, let's set up the patient. You are the nurse. You are reviewing the morning laboratory values for a patient who has a documented history of heart failure.
Okay, heart failure. Got it.
You are scanning through all that data we talked about earlier, the blizzard of information. And out of all the noise, your eyes lock onto one specific value.
The snowflake.
The snowflake. It's a potassium level of 3.5 milliequivalents per liter. And this brings us right into the very first cognitive skill of the model, which is recognizing cues.
Yes, recognizing cues.
So how does this fit into the broader picture we discussed in part 1?
Well, recognizing cues overlaps directly with the assessment phase of the traditional nursing process, but it is much more granular.
Granular how?
Assessment is the gathering of all the information, right? You're just pulling it in.
Right.
Recognizing cues is the active cognitive filter you apply to that gathered information.
Okay, so it's not just collecting, it's sifting.
Exactly. It is the ability to sift through massive amounts of environmental and clinical data to determine what is actually relevant and of immediate concern versus what is just background noise.
But I want to push back on that idea of background noise for a second.
Okay, go for it.
Because we are asking human brains to process thousands of data points in modern healthcare settings. With the electronic health records, predictive algorithms, and smart monitors, we are in an era of intense alarm fatigue, you know?
Oh, absolutely. Alarm fatigue is a massive issue.
So how does a nurse actually give themselves permission to ignore certain pieces of information? I mean, isn't all data technically relevant to the patient's body?
That is a phenomenal question, and it addresses one of the most dangerous phenomena in modern medicine, which is cognitive overload.
Right. Just having your brain freeze up.
Yeah, precisely. Yes, all data is technically a reflection of the patient's body. The temperature of their toes, the exact hue of their skin, their family history of arthritis.
But you can't focus on all of it at once.
You can't. If you try to process every single data point with equal weight in real time, your brain will simply freeze. You will be completely paralyzed by analysis.
Analysis paralysis.
Exactly. Recognizing cues is about survival, both for the patient and for the clinician's cognitive bandwidth. You are not really ignoring data permanently. You are constantly prioritizing what demands immediate processing.
So it is like being a security guard watching a bank of like 50 camera feeds.
Oh, that's a good way to put it.
Yeah, you cannot actively focus on every single person walking down the street, but the moment someone puts on a ski mask in July, your brain snaps to that specific monitor.
That is the absolute essence of it. A cue is a deviation from the expected baseline. Sometimes the cue is a number on a screen, like our potassium level, but often it is far more subtle.
Like what? What kind of subtle things?
Well, it might be a slight change in the patient's tone of voice. It might be a subtle grimace when they shift their weight in bed. Or it might even be a family member just saying, he just doesn't seem like himself today.
Wow, so you have to pick up on those tiny, almost invisible things.
Right. True clinical judgment involves capturing those seemingly minor anomalies from the environment before they cascade into major physical failures.
Okay, let's look at our specific ski mask then, or our snowflake. The potassium level is 3.5 milliequivalents per liter. Why did the nurse's brain snap to that specific number on the monitor?
To understand that, we have to recognize that pulling a cue from the noise is only the very first microsecond of the process.
The first microsecond.
Yeah, a cue cannot just sit in isolation. Think of it like a puzzle piece. A puzzle piece does not tell you what the picture is until you look at its shape and try to fit it into the surrounding pieces.
Oh, I see.
The moment you recognize the cue, your brain instantly shifts into the second cognitive skill of the model, which is analyzing cues.
Analyzing cues. And this overlaps with the diagnosis phase of our traditional nursing process, right? Specifically the first half where we are interpreting data.
Correct. Analyzing cues requires you to consider the broader context of the client's history and their specific current situation.
So context is key here.
Context is everything. You have to interpret how that isolated cue relates to their overall condition. You are actively searching for other pieces of data that either support or contradict the cue, and you are trying to identify potential complications that might arise from it.
Okay, so let's look at our number. 3.5 milliequivalents per liter. Now, if you look at a standard laboratory reference range, a normal potassium level is typically between 3.5 and 5.0, right?
That's right.
So in total isolation, That number is actually normal. I mean, it is on the very bottom edge of normal, but it is normal. A computer might just flag it as green and move right on.
Exactly. And if you are practicing medicine without clinical judgment, if you are just blindly following a static checklist, you look at that number, you see it falls within the acceptable parameters, and you do absolutely nothing.
Just check the box and walk away.
Yep. And in this specific scenario, doing nothing would be the first domino falling toward a catastrophic outcome.
Wow. Okay, walk us through the context. What is the nurse analyzing here that turns a quote-unquote normal number into a glaring red flag?
Well, the nurse integrates the cue with the patient's medical history and their upcoming treatments. So the analysis looks like this. Fact 1, the potassium is 3.5, which is borderline low.
Right. Hang on the edge.
Fact 2, this patient has a documented history of heart failure.
Uh-huh.
Fact 3, because of that heart failure, this patient is scheduled to receive a medication in about 10 minutes.
What kind of medication?
A powerful diuretic called furosemide.
Furosemide. Okay, so it reminds me of mixing common household chemicals, you know.
Oh, the bleach and ammonia thing.
Yes. You have a bottle of bleach, totally safe on its own if used correctly.
Right.
And you have a bottle of ammonia.
Yeah.
Totally safe on its own.
Right.
But when you analyze them together, when you pour them into the same bucket, you suddenly realize you are creating a highly toxic, dangerous chemical reaction.
That is perfectly said.
Individually benign, but contextually lethal.
The chemical reaction analogy is perfect because we are actually dealing with actual biochemistry here. To understand why this combination is a potential disaster, we need to dive into the physiology of what that diuretic actually does inside the human body.
Let's get into the mechanics of it. I love this stuff. Why is the patient getting furosemide in the first place? And what does it actually do?
So heart failure essentially means the heart muscle has become weak or stiff, right? It is no longer pumping blood forward efficiently.
The pump is broken.
Exactly. And when the forward pump fails, fluid starts to back up into the system, kind of like a traffic jam behind a car accident.
Okay, I can visualize that.
So that fluid accumulates in the tissues, causing swelling in the legs, which we call peripheral edema. And even more dangerously, it can back up into the lungs, causing pulmonary edema.
So the patient is essentially slowly drowning in their own fluid because their heart cannot push it out of the way. It sounds terrifying.
It is terrifying. So the physician orders a diuretic like furosemide. Now, this medication travels down to the kidneys and targets a very specific area called the loop of Henle.
The loop of Henle. Got it.
Yes, it blocks the kidneys from reabsorbing sodium and chloride. Now, a fundamental rule of biology is that water always follows sodium.
Water follows sodium.
Right. So if the sodium is being blocked and flushed out into the urine, a massive amount of water gets flushed out right along with it.
Oh, wow. So it just drains them out.
Exactly.
Yeah.
This pulls all that dangerous fluid out of the patient's lungs and legs.
Well, that sounds like exactly what the patient needs, right? We are fixing the traffic jam.
Yeah.
Where's the toxic combination here?
Here's the catch. The problem is that furosemide is not a precision sniper rifle. It is a shotgun.
A shotgun.
Yeah. As it aggressively washes out the sodium and the water, it also indiscriminately washes out other crucial electrolytes. And the most significant casualty in that process is potassium.
Oh, no.
Yeah. Furosemide dumps potassium straight out of the body into the urine.
Okay, now the pieces are coming together. The nurse recognized the cue. The patient's potassium is currently 3.5 milliequivalents per liter. It is hanging on by a thread at the absolute lowest limit of normal.
Right. And the nurse analyzed that cue against the impending action. If you administer this diuretic right now, you're going to aggressively wash out whatever potassium the patient has left.
It'll just bottom out.
Exactly. That borderline number of 3.5 is guaranteed to plummet down to 3.0 or even 2.5. The patient will instantly cross the threshold into a state of severe hypokalemia, which is dangerously low potassium.
So we have successfully analyzed the cue. We see the train coming down the tracks. We know the collision is going to happen if we do not intervene. And this naturally propels the nurse into the third cognitive skill of the model, right?
Yes, which is prioritizing hypotheses.
Prioritizing hypotheses. And this aligns with the second half of the diagnosis phase in the traditional model, where we take all the problems we have identified and we rank them.
Rank them by severity. We literally have to decide what is going to kill the patient first.
That is so intense. I want to break down the mechanics of prioritizing. The definition says the nurse must examine all the possibilities about what is currently occurring, evaluate them, and rank them based on urgency and risk.
Right. You determine which health conditions are the most likely, which are the most serious, and fundamentally why they are serious.
Because in any complex medical scenario, you rarely have just one problem, do you?
Never. You have competing realities. You have a patient whose body is failing in multiple ways simultaneously, and interventions that help one system often harm another. It is a constant balancing act.
Let's lay out the competing hypotheses in our scenario for the listener. Hypothesis 1, the patient has heart failure and desperately needs this diuretic. If they do not get it, the fluid continues to back up, their lungs fill with fluid, and they go into severe respiratory distress.
Suffocation, essentially. And hypothesis 2, if we give the diuretic to save the lungs, we crash their potassium levels.
Right, so what exactly happens when potassium drops too low? Why is that such a terrifying prospect?
Okay, so potassium is not just a nutrient, like vitamin C or something. It is the fundamental electrical currency of the body.
Electrical currency.
Yes. Every single time a muscle contracts, especially the cardiac muscle, it relies on a highly precise exchange of sodium and potassium across the cell membrane.
Oh, I see.
This exchange creates the electrical spark, the action potential, that tells the heart to beat in a steady, synchronized rhythm.
So it is quite literally the wiring of the house.
Precisely. It is the wiring. If you strip the potassium out of the blood, you lose the resting membrane potential of those cardiac cells.
And what happens to the wiring then?
The electrical wiring gets incredibly irritable and unstable. The heart goes from a smooth, steady beat to a chaotic, disorganized quivering.
Oh, wow.
We call these cardiac arrhythmias, and a severe deficiency can lead straight into ventricular fibrillation, which is a lethal cardiac arrest rhythm.
Okay, I want to focus on the impossible choice here, because this is where the textbook ends and real clinical judgment begins, doesn't it?
It absolutely does.
You have a patient whose lungs might fill with fluid if you withhold the drug, meaning they suffocate. But their heart might literally short-circuit and stop beating if you give the drug.
It is a nightmare scenario for a novice.
How do you rank two potentially fatal outcomes? Like, how do you choose?
It feels like an unsolvable dilemma, but clinical judgment relies on a very strict, evidence-based hierarchy of risk. You have to look at the chronological timeline of the threats.
The timeline.
Yes. You ask yourself, what is going to cause irreversible harm the fastest?
Okay, we're talking about the classic airway, breathing, circulation hierarchy here?
Yes, that is a foundational tool, but we are also looking at the difference between mechanical failure and electrical failure.
Okay, break that down for me.
Well, fluid accumulating in the lungs, pulmonary edema, is a terrifying and dangerous mechanical issue. However, it is typically a gradual process.
Gradual, even though it's suffocation.
Yes, it takes time for the fluid to build up, and we have intermediate interventions we can deploy, like applying supplemental oxygen or sitting the patient upright, just to buy us some time.
So you can see the water rising, so to speak.
Exactly. You can monitor the rising water, but an electrical failure of the heart caused by profound hypokalemia.
Yeah.
That does not happen gradually.
It's sudden.
The heart does not give you a warning. It can happen in an absolute instant. 1 second the patient is talking to you, and the next second their heart has gone into a fatal arrhythmia and they are completely unresponsive.
That is chilling.
It is. Immediate, sudden, life-threatening electrical instability will always take precedence over a slower developing mechanical fluid issue.
That makes profound sense when you frame it chronologically. The electrical failure kills the patient in 5 seconds. The fluid backup kills them in 5 hours.
Exactly.
Therefore, protecting the heart's electrical stability by preventing that drop in potassium must be the absolute highest priority.
Spot on. You have now successfully prioritized your hypotheses. You have identified the apex threat.
The apex threat. I like that.
So the next step is figuring out how to neutralize that apex threat without completely abandoning the treatment for the heart failure, because we still need to fix the lungs.
Right, which brings us to the fourth cognitive skill in the clinical judgment measurement model.
Generating solutions.
Generating solutions, yes.
And this connects directly to the planning phase of our traditional nursing process. We know what the primary threat is. Now we need a blueprint to diffuse it.
Generating solutions involves a two-part thought process. First, the nurse identifies the expected, desirable patient outcomes. You have to ask, what does a successful resolution look like?
Visualizing the finish line.
Exactly.
Yeah.
Second, using those prioritized hypotheses, the nurse plans specific evidence-based actions to achieve those outcomes safely.
So our desired outcome here is a delicate balancing act, right? We need the patient to receive their much-needed diuretic so their lungs stay clear, but we must ensure they do so without suffering a catastrophic drop in their potassium levels.
Right. We want the benefit of the therapy without the lethal side effect. And here is a vital component of the generating solutions phase that I think often gets overlooked. It is not just about planning what you are going to do. It is equally about identifying the actions that must be explicitly avoided.
Yes, identifying contraindications. It is so crucial.
So applying this to our specific scenario, the active solution generated by the nurse is to temporarily hold the administration of the furosemide.
Hold the drug.
Right. Do not give the diuretic right now. We must delay the therapy until we have a plan in place to supplement the patient's potassium simultaneously.
That is the generated solution.
I really want to spend some time on this concept because it shifts the entire paradigm of what people think nursing actually is.
Oh, completely. It shatters the stereotype.
Because if you ask a layperson what a nurse does, they will almost always describe movement.
Push your medications, running around.
Pushing medications, changing sterile dressings, starting intravenous lines, running to a code blue. Action is always equated with physical intervention. But you are saying that doing nothing, intentionally choosing to hold a medication that a physician has specifically ordered, is considered an active, powerful solution in this cognitive model.
It is arguably the most powerful and sophisticated action a healthcare professional can take.
Really?
Stopping. Yes. Restraint is an incredibly active cognitive choice. It requires immense confidence in your own analysis of the data. You have to know you are right.
Because you are actively defying an order. It's the ethical principle of non-maleficence, right? The obligation to do no harm.
Absolutely. The foundational directive of healthcare is to act in the patient's best interest. You have a legal and an ethical mandate to protect the patient from foreseeable harm.
And a physician's order isn't a suicide pact.
No, exactly. If a physician wrote an order for a medication 4 hours ago, but the patient's physiology has fundamentally changed in the last 30 minutes, blindly following that order is not just bad practice, it is negligent. The nurse is the human being standing at the bedside in real time. Choosing to withhold a medication because your clinical judgment tells you it will cause immediate lethal harm is the ultimate safety net of the medical system.
It takes a lot of courage to be that safety net, doesn't it?
It takes tremendous courage.
Because it is easy to just scan a barcode and push a pill. That's the path of least resistance. It takes real clinical bravery to stop the assembly line and say, no, this is dangerous.
And that bravery transitions us perfectly into the fifth cognitive skill. Because a generated solution is really just a theoretical plan floating in your head until you execute it in the real world.
Right, which brings us to taking action. And this overlaps seamlessly with the implementation phase of the traditional nursing process. We have our plan, we are holding the drug, and we need a potassium supplement. Now we have to make it happen.
Taking action is defined as deciding which interventions address the highest priorities and then actually implementing them. And just as we discussed with restraint, taking action goes far beyond physical, hands-on care.
It's not just the physical stuff.
Not at all. Implementing includes ongoing assessment, patient education, meticulous documentation, and critically, consulting with other members of the interdisciplinary healthcare team.
So communication as a clinical intervention.
Exactly. The most consequential actions you take are often spoken.
So in our heart failure scenario, the nurse takes action by picking up the phone and contacting the primary healthcare provider. And this isn't just a casual chat, is it?
No, you don't just call and say, hey, I'm worried.
The nurse has to concisely communicate the analyzed cues, the prioritized risk, and the generated solution.
Very specifically.
They explain the history of heart failure, the impending diuretic order, the borderline potassium level of 3.5 milliequivalents per liter, and the severe risk of inducing a fatal arrhythmia if the medication is given without a supplement.
This is where we really see the power dynamic of healthcare operating at its best. The nurse is not just calling to say, I have a problem, tell me what to do.
Right, that would be a passive approach.
Sure. Very passive. With strong clinical judgment, the nurse is calling to say, I have identified a critical risk, I have analyzed the mechanism of that risk, and I am recommending a specific solution to mitigate it.
It is collaborative decision-making. Two professionals working together.
And it is absolutely necessary because of the fragmented nature of modern medicine.
Fragmented how?
Well, the physician or provider who wrote the order for the diuretic might have done so during morning rounds, long before the morning laboratory values were processed by the computer.
Oh, so they didn't even see the 3.5 potassium.
Right. Or perhaps they are a covering provider who is managing 60 patients today, and they simply miss the nuance of this specific patient's baseline potassium drifting downward over the last 3 days.
It's the Swiss cheese model of errors.
Exactly. The Swiss cheese model.
There are holes in every layer of defense.
Ugh.
The software, the pharmacy, the prescribing provider. The nurse is the final solid slice of cheese that stops the error from reaching the patient.
The final checkpoint. So as a result of this highly structured, informed communication, the nurse receives a new verbal or electronic order from the provider.
What's the new plan?
The new plan is to administer 20 milliequivalents of oral potassium chloride right alongside the furosemide.
Boom. A perfect execution of the planned solution. We balance the scales. We give the potassium to replace what the diuretic is about to flush out.
You protect the electrical system of the heart while simultaneously fixing the mechanical fluid back up in the lungs. It's a win-win.
I have to laugh because if you watch television medical dramas, they always make taking action look so incredibly cinematic.
Oh, always.
Someone is sprinting down a hallway, straddling a gurney, doing chest compressions, shouting for a crash cart while dramatic synthesizer music plays in the background.
With a defibrillator in each hand.
Right. But based on our breakdown here, the most heroic, life-saving action is often just a nurse, standing quietly at a workstation, making a brilliantly informed phone call.
That is the absolute truth. The cinematic moments certainly happen, but they are often the result of a failure in clinical judgment somewhere upstream.
Wow. Wait, say that again?
If you miss the cues, you end up doing chest compressions.
That is profound.
It's true. The vast majority of lives in a hospital are saved quietly through diligent analysis, pattern recognition, and clear communication long before the crisis ever erupts.
So the action has been taken. The phone call was successful. The new order was received. The nurse walks into the room, explains the new plan to the patient, and safely administers the oral potassium supplement along with the diuretic medication.
Task accomplished.
The task is checked off the list. The boxes are green in the electronic health record. But true to the nature of complex biological systems, clinical judgment does not just clock out when the task is done. The cognitive engine doesn't power down just because the pill was swallowed.
Which leads us directly into our sixth and arguably most dynamic cognitive skill in the model: evaluating outcomes.
Evaluating outcomes. This is the direct counterpart to the evaluation phase of the traditional nursing process. Let's look at the mechanics of this final step.
Evaluating outcomes requires the nurse to observe the actual real-world physical outcomes in the patient and compare those realities to the expected theoretical outcomes that were identified back during the planning phase.
So it's a reality check.
A total reality check. You have to ask yourself a very blunt question. Did the intervention I just performed actually work?
Right.
Were the actions effective? Were they completely ineffective? Or did they make absolutely no difference at all to the trajectory of the patient's condition?
It is the ultimate moment of accountability. You theorized, you acted, and now the universe tells you if you were right or wrong.
In our scenario, the nurse returns to the room 30 minutes, an hour, and 2 hours after giving the medications. They are actively gathering a whole new set of data points to validate their hypothesis.
They are looking for proof that the scales stayed balanced, right?
Exactly.
So they check the heart monitor. Is the heart rate still steady and regular? Are there any signs of those erratic electrical disturbances we were trying to prevent? Then they pull out their stethoscope and listen to the patient's chest.
Listening for the fluid.
Right. Are the lung sounds becoming clearer? Is the patient breathing easier, showing that the diuretic is successfully pulling that excess fluid out of the respiratory system? They check the legs. Is the peripheral edema reducing?
The nurse is essentially proving or disproving their own clinical theory in real time.
But let's explore the alternative reality here. Because healthcare is rarely as clean and tidy as a hypothetical scenario, you know.
Very true.
What happens if the action was ineffective? Let's say the nurse goes back into the room an hour later, and the lung sounds are still terrible. Or worse, the heart monitor starts showing some premature ventricular contractions, those early warning signs of electrical instability.
The quivering starts.
Right. What then? Do you just document that the intervention failed? Sit back and hope the next shift fixes it?
Absolutely not. And this is perhaps the single most crucial concept for anyone trying to understand the clinical judgment measurement model.
Okay, lay it on us.
This model is not a straight line. It is not a highway with a final destination where you park the car and turn off the engine. It is a circle.
As a circle.
It is a highly iterative, continuous loop. If the expected outcome is not met, or if the patient's condition deteriorates in a new way, the process does not end. It loops instantaneously back to step one.
Back to recognizing cues.
Exactly. Let's take your example. The intervention failed. The patient swallowed the oral potassium, but 30 minutes later, they became severely nauseated and vomited.
Oh, wow. Okay, so the potassium never actually absorbed into their bloodstream.
Right. So the nurse is immediately back to recognizing a new cue. The patient vomited the supplement, but the diuretic is already in their system working.
That's a bad combination.
Very bad. The cognitive engine fires up again. You analyze this new cue in context. The protection is gone, but the threat is active.
So you prioritize a new hypothesis.
Yes. You prioritize a new hypothesis. The patient is now at immediate risk of hypokalemia again, but oral supplements are no longer viable because of the gastrointestinal distress.
Because you have to generate a new solution.
You generate a new solution. We need intravenous potassium replacement, and we need an antiemetic medication to stop the vomiting.
And then you take action.
You take new action, you call the provider again, you explain the new development, you get the new orders, you establish an intravenous line, and you administer the new medications. And then
you evaluate the outcomes all over again. Does the intravenous line hold up? Does the intravenous potassium cause burning at the site? Does the vomiting stop? It is a continuous, living, breathing cycle of assessment and adaptation.
it is exactly like breathing. You don't just take one deep breath in the morning and say, well, I successfully completed the breathing process for today.
Right.
You have to keep doing it, constantly adjusting the depth and rate of your breaths based on the demands of your environment, whether you are sitting quietly on a couch or sprinting up a flight of stairs.
The cognitive engine is always running, adapting to the terrain. It only stops when the patient is finally discharged or their care is formally transferred to another team.
It is exhausting, but it is the absolute essence of professional nursing.
This has been an incredibly illuminating journey through the architecture of a healthcare professional's mind. To briefly summarize everything we have unpacked today for you listening, the clinical judgment measurement model takes the foundational, traditional nursing process, that broad map of care, and it essentially supercharges it.
It puts the engine in the car.
Exactly. It transforms nurses from being passive technicians who merely follow algorithmic instructions or static checklists into active, dynamic guardians of patient safety.
Guardians, I love that word for it.
It demands that they constantly recognize, analyze, and act on subtle, shifting cues in real time. It is the framework that allows a human being to translate their static, textbook knowledge into dynamic, life-saving action.
It is the ultimate evolution of the profession. It places the cognitive responsibility squarely on the shoulders of the clinician at the bedside, acknowledging that they are the critical nexus point between data and survival.
It is a massive responsibility, but an absolutely vital one. We've covered a lot of ground today, from the biochemistry of the kidneys to the psychology of interdisciplinary communication. But before we wrap up this session, I want to leave you, our listener, with a final provocative thought to mull over. Something that builds on everything we have discussed about this deeply human cognitive process.
Oh, I'm curious. Let's hear it.
So we have spent this entire deep dive talking about how the clinical judgment measurement model relies heavily, almost entirely, on a human being's organic ability to recognize and contextualize subtle cues in real time.
Yes.
The human nurse has to look at the potassium level, look at the patient's history, remember the pharmacology of the medication, and connect those dots using their own biological neural network.
Right, their own brain.
But as we look toward the future, modern medicine is becoming increasingly automated. We are becoming more and more reliant on electronic monitoring systems, smart intravenous pumps, and predictive artificial intelligence algorithms that are explicitly designed to scan the data and flag these exact issues for us.
The machines are learning to recognize the cues.
Exactly. The computer might soon be the one to just pop up and say, "Warning, diuretic ordered with low potassium."
Oh.
So here's the question for you to ponder. As these systems become more prevalent, how will we ensure that our natural human ability to critically analyze these cues doesn't atrophy?
Oh, that is a great question.
Because if we stop doing the heavy cognitive lifting ourselves, do we lose the muscle? Will this incredible new technology enhance our clinical judgment, freeing our minds up to look at the bigger, more holistic picture of the patient's life?
We can only hope.
Or will we slowly become too reliant on the artificial intelligence and the machines to do the recognizing and the analyzing for us, ultimately losing our own internal cognitive engine in the process?
It is a phenomenal existential question for the future of healthcare. As the technological landscape changes, the way we teach and apply these 6 cognitive skills will undoubtedly have to evolve right alongside it.
We have to adapt.
We have to ensure the technology remains a tool that serves the clinician rather than a crutch that replaces human intuition. Because at the end of the day, when the power goes out or the algorithm encounters a rare scenario it wasn't trained for, well, the ultimate responsibility for the patient's life remains with the human being standing at the bedside.
The human element can never be fully outsourced. It is definitely something to think critically about as you move forward in your practice and encounter these new technologies. Well, we want to thank you so much for tuning into this deep exploration on the Nursing Launchpad program right here on the Licensed Practical Nurse Launchpad channel.
It's been a pleasure.
Keep thinking critically, keep connecting the dots, trust your cognitive engine, and we will see you next time.